So next we've got Charlotte Manisty. Thank you very much for coming up. And Charlotte's going to talk to us about immune checkpoint inhibitors.
Perfect. Thanks for the invitation. And so I'm actually going to come about it from completely the other direction. So here we're looking at patients who have been given treatments that actually stimulate the immune system, and then looking at the effects on the cardiovascular system as a result of that. My relevant disclosure here is I am not an immunologist, as will become very clear quite soon. So it tend to be when you're treating cancer patients with conventional chemotherapy, you're giving them drugs that essentially target all rapidly dividing cells, so not selective particularly for those tumor cells. With immunotherapy, what you're trying to do is to harness the body's own immune system. Sorry, is this very loud, by the way? It sounds very loud to me. Okay, fine. So you're trying to harness the body's own immune system specifically to target those cancer cells and not the healthy cells. This is not really a new concept. It's been described since the late 19th century, but it wasn't until 2018 that these two gentlemen received the Nobel Prize for Medicine as a result of their discovery of immune checkpoint inhibitors and their use in cancer patients. And it's not an overstatement to say that these have revolutionized and are now the cornerstone of modern cancer therapy. Metastatic melanoma, if you look at the 3-year survival with conventional chemotherapy, 15%. We now have data out to 5 years showing that over half patients will still be alive out to 5 years. So it really has revolutionized treatment that's out there. We have now 9 approved immune checkpoint inhibitors that are used across more than 20 tumor types, including in early stage cancer. And if we look, there are about 40% of malignancies now would be eligible for treatment with immune checkpoint inhibitors. So this really is becoming part of the whole of oncology. And if you read mainstream media, you'd think that the biggest grossing drugs globally now are the Ozempic and Mounjaro, but actually pembrolizumab, PD-1 inhibitor, is the biggest grossing revenue generating drug currently out there. And if you look in the numbers 10 to 20, half of those are immune checkpoint inhibitors. So how do they work? Well, the immune checkpoint is your body's own braking system on the immune system that helps to reduce autoimmunity, etc. And tumor cells use this to evade the immune response and to rapidly divide. So if you inhibit that using monoclonal antibodies, then you can activate the body's own immunity against cancer. And so we now have various targets, CTLA-4, the PD-1 and PD-L1 ligand, and LAG-3, and those are the monoclonal antibodies associated with it. So fantastic, that's all great, but where's the downside? And this is it. So there's a high instance of immune-related adverse events that can affect almost every organ in the body. But it wasn't until 2016 that we saw the cardiovascular effects. So this was a description of 2 patients with fulminant fatal myocarditis, both of whom presented with conduction abnormalities or arrhythmias, and both of whom had a florid myocarditis on post-mortem. We now know that this is relatively rare, probably about 1 to 2% of patients receiving immunotherapy, but think of the huge numbers of patients that are receiving it. And the fatality rate of 40%, which was originally quoted, is probably not as high as that now. So I think that's a slight overstatement, but it still does have a high fatality rate. So if we look at the incidence, about 1 to 2% of patients, it tends to present early during treatment. But patients, after they've had an immune checkpoint inhibitor, it can stay around and still have effects for up to about 120, 150 days, even after stopping the drug. It's quite an arrhythmogenic myocarditis. There's an overlap with myositis and myasthenia. And as you will hear, the diagnosis is extremely challenging in these patients. Symptoms are non-specific. Often fatigue is the primary presenting symptom, which you can imagine in a cancer population is a very difficult symptom to tease out. And the other thing to say is that echocardiography is generally normal. So more than half of patients will have a normal ejection fraction. Major adverse cardiovascular event rates are extremely high, up to about 40 to 50% of patients will have complete heart block or ventricular arrhythmias. When we look at troponin, which obviously all of us use as our main biomarker for looking in myocarditis, you can see that it's very dependent on what type of troponin you use. So troponin I is highly selective for cardiomyocytes. Troponin T is also seen in the skeletal muscle. And so whilst most of them will get an acute rise of both biomarkers in most patients, you can see that troponin T, if it's less than 32 times the upper limit of normal, has a low risk of MACE, but you can still have MACE even after your troponin I has normalized if your troponin T remains elevated. And so it can be quite disconcerting. You've treated your patient, their troponin I's come down quite nicely, and you think, oh, we're out of the woods, but actually their troponin T remains elevated at that stage. So we've heard a lot about cardiac MR, about how wonderful it is. We have these mapping quantitative techniques to really understand and diagnose myocarditis in most settings. So does it work well here? Unfortunately, my feeling is, and I'm an MRI person as well, I don't think it does really. So this was the initial study. This was a 28-center registry, albeit of only 100 patients. But although the majority had normal ejection fraction, actually less than half of them had any late gadolinium enhancement, less than a third of them had abnormal T2 stir, and 42% of them had no abnormalities in tissue characterization. And tissue characterization had no impact at all on terms of prognosis. So that's not particularly great. But perhaps you say, well, actually, we should be using mapping. Well, even when we use mapping, we can see that only 78% of patients have abnormal T1 values, and less than half of patients have abnormal T2. So the normal diagnostic parameters that we use for MRI diagnosis of myocarditis don't really apply quite so well here, albeit that probably abnormal T1 is the best MRI predictor of outcome in these patients. So certainly we know that parametric mapping does help, and probably we should be doing a full study including mapping in these patients because it can help reduce the need for endomyocardial biopsy. If your scan is either completely normal or completely abnormal, then you definitely don't need biopsy. If you're in the middle, you may consider treating empirically, or you may consider giving an endomyocardial biopsy. But certainly, if you look at MRI phenotypes in patients with viral myocarditis as compared to immune checkpoint inhibitor myocarditis, they're very different. So we see less evidence of edema in immune checkpoint inhibitor myocarditis. We see less scar, and the distribution of scar is different. So it's not that infralateral late gadolinium enhancement that you get with viral myocarditis. It's mainly septal scar, and that septal scar does have some prognostic impact. So diagnosis is really challenging. And the other thing, and I think this is really important, the impact of getting the correct diagnosis is even more important, because if you diagnose someone with immune checkpoint myocarditis, you have to stop the immune checkpoint inhibitor. You're giving them a treatment that potentially is saving their life. If you stop that, that's problematic. You then give them steroids, and we know that steroids will reduce the effect of the immune checkpoint inhibitor that they'd had before. So you're actually even attenuating the effect of the beneficial drugs that you've given them. So you really need to get it right. And on the other side, we know that those patients are also more likely to have a more malignant course from their myocarditis. So if you don't diagnose this and don't treat it, then again, your problems are kind of exacerbated. So can we just monitor these patients with troponin throughout their treatment and pick it up early? Unfortunately, I don't think even that's very straightforward. We know that asymptomatic troponin I elevations happen in over 10% of patients, and the positive predictive value of an elevated troponin I in this admittedly one study was only about 12%. So even that's not particularly helpful. So anyone who's interested in novel biomarkers discovery, this is a really ripe area for research. So we need help here. So the definition is similar to normal myocarditis, but there are some additional things. So you can see the things that I've underlined. They're related to other immune-related adverse effects. So if your patient's got these, then you do need to consider checkpoint inhibitor myocarditis. How do we monitor these patients during treatment? This is the European Society of Cardiology guidelines, and I actually don't think they're very helpful. So they suggest that you should be doing serial troponin monitoring during treatment. I've already shown you that actually that's probably not very helpful. And they also suggest that patients who are at high cardiovascular risk at baseline should be monitored more carefully. And actually, again, we know that there's no association between immune checkpoint inhibitor myocarditis and baseline cardiovascular risk. So I think we really have very little evidence to support what the recommendations are of the guidelines. But treatment is largely about stopping the immune checkpoint inhibitor, admitting your patient, monitoring them, and then giving them high-dose steroids. And the recommendations currently in the guidelines are for really very high-dose IV methylprednisolone. But many patients don't have a very good response to that. So what do you do next? And you'll see by the list here, the answer is we don't really know. We tend to, different institutions will do different things. Probably MMF is the most commonly used second-line agent, but I wouldn't say we've got a huge amount of evidence for that. And then what do you do if your patient's had mild immune checkpoint inhibitor myocarditis, has recovered well? Can you then give them the checkpoint inhibitor again? Again, no one knows the answer. So again, evidence-free zone for which we need more data. So triple M syndrome, this is the kind of thing we all fear. We see it not infrequently. It's where you get this overlap syndrome of myocarditis, myositis, and myasthenia gravis. These patients deteriorate very quickly. They have a very, very high mortality, and treating them again is difficult. One of the main reasons is if you give high-dose steroids to someone with myasthenia, you don't help them either. So again, treatment's very difficult. And this is just, I know it's very small, you can't read it, but essentially this is the range of different therapies that people have used in published papers as second-line agents. And you can see that, again, nobody really has much of a clue, and they just throw the book at these patients. There is some early evidence for using the combination of abatacept, which is a CTLA fusion protein, which induces T-cell anergy, together with ruxolitinib, the JAK inhibitor, in these patients. The only data we've really got is from a single center where they took two time periods where patients were either treated without ruxolitinib and abatacept or without it. So you can see the mortality between those different two time points was very significant. So over 60% versus 3% mortality. This is a small retrospective observational data set, and I don't think we can draw much from that. But the good news is that there are two proper, well-designed clinical trials ongoing to try and answer this question. So if your patient does develop checkpoint inhibitor myocarditis, what's the risk? How do you determine whether your patient's going to do well or badly? So this is very recently, just within the last couple of weeks, been published in the European Heart Journal. It's a multi-center registry of over 700 patients looking at the 30-day incidence of major adverse cardiovascular events with event rates of about 30% and cardiovascular death in about 13% of patients. They looked at the factors that induce risk of major adverse cardiovascular events, and it includes ECG, echo, troponin, but also thymoma, and I'll talk about that in a minute. And we could see that it was a good stratifier of risk. They then externally validated it. And then the bit that I'm most interested in is the patients who had a very low risk score, so a risk score of 0. In those patients, they actually didn't even immunosuppress them at all, and they had 0 event rates. So that's quite helpful. So you can actually perhaps identify those patients that don't need any immunosuppression. I just wanted to mention this, the fact that we know that also these patients have accelerated atherosclerosis. And so this is a retrospective matched case control study of over 5,500 patients, all of whom had lung cancer and were either treated with immunotherapy or not. And you can see that their risk of atherosclerotic events was 3-fold increase compared to the patients not treated with immunotherapy. And if you looked at patients before and after receiving immunotherapy, there was a 4-fold increased risk post initiation of immunotherapy. So it's not just the myocarditis, but it's also the atherosclerosis that we need to think about. And actually, there's some imaging data here, albeit not a huge amount that's available. So this was a study looking at simple CT scans and looking at thoracic aortic plaque. And we could see that progression was almost twice as high in patients receiving immunotherapy as those who didn't. And it seems to be mainly non-calcified plaque that we see in the patients receiving immunotherapy. This is work that Mark and Ninian Lang did relatively recently in cancer patients, comparing a similar cohort of patients either receiving VEGF inhibitors plus checkpoint inhibitors, or checkpoint inhibitors alone. And they had baseline scans and then scans follow-up after 24 weeks. It's a relatively small study, and they actually didn't see any significant changes in the CT, the FDG PET levels, and they didn't see any obvious biomarkers that were going to help with that. But I know that this is early work, and I think others have found that FDG PET is not particularly helpful in this population. So we need your help, Mark, basically to tell us what we should be looking at, to be honest. So what's the mechanism? Again, I'm not an immunologist, so apologies. So we know that the checkpoint inhibitors will stimulate T cells and anti-tumor immunity, but we know it causes heart damage, and that's partly because the cardiac myocytes express ligands that PD-1 ligands that are also impacted by the checkpoint inhibitors. And so these autoreactive T cells recognize the cardiac antigens like alpha-myosin heavy chain and then will cause an immune response. There's pretty good mouse models out there of knockout mice which have catastrophic myocarditis related to the CTLA-4 knockout, or partial myocarditis in those patients with PD-1 knockout. Although, sorry, there's mice with PD-1 knockout. And we know that that's CD8 T cell driven, with higher levels of CD8 T cells in those mice, knockout mice, and that's blocked by anti-CD8 therapies. We also know that CXCR3 pathway is involved with elevated levels of both CXCR3 and also activated macrophages in the heart of knockout mice. And similarly, if you give healthy mice immunotherapy and then give them anti-CXCR3 therapies, then essentially you can massively attenuate the rates of myocarditis and improve the survival in mouse models. Let's go through that. So just really of relevance to this population, we know that baseline autoimmunity is associated with higher cardiovascular events in patients receiving checkpoint inhibitors. So this was a nice study of over 6,000 patients, of whom 250 patients had pre-existing autoimmune disease. All the patients had immune checkpoint inhibitors, and the patients with autoimmune disease were matched with those who didn't have autoimmune disease. And what we can see is the rates of cardiovascular events were much higher in those patients with autoimmune disease and the checkpoint inhibitors. And we also showed that conventional cardiovascular risk factors in this context were not really prognostic. The thymus is highly relevant here. We know that patients with thymomas have almost tenfold risk of myositis, myasthenia, and myocarditis than patients with other tumors with immune checkpoint inhibitors, and that their outcomes are worse. And acetylcholine receptor antibodies are much more prevalent in those patients who do worse. And this is largely because the thymus is involved with central tolerance. And so because the alpha-myosin is not really expressed within the thymus, it kind of escapes that immune activation. And so you're more likely to get alpha-myosin specific T cells that then exit the thymus and then can activate the immune system and lead to cardiomyocyte damage. So hopefully it's clear that we've actually got a huge number of evidence gaps. And the question is, why don't we know more? Surely we should. Well, the first thing to say is this is quite a difficult patient group to study. These are patients who have really got quite conflicting priorities. They've got a cancer that's being treated. They're already seeing multiple different physicians. And the thing they're probably worried about most is their cancer, not their cardiovascular disease. We also tend not to have baseline information in these patients before they actually start treatment with the checkpoint inhibitors, and therefore understanding what's related to their pre-existing cardiovascular state and what's related to the drug can be difficult. There's obviously shared risk factors, and also because of the rapid drug development that we see in this field, many of these drugs are being released without huge amounts of safety data, particularly not in terms of things like long-term cardiovascular effects. Obviously, drugs are also given in combination, so VEGF inhibitors plus TKIs, and often many of these drugs are also cardiotoxic as well. So kind of teasing out each of the contributions can be very difficult. And so really we need to try and collect data in a bit of a more systematic way, and we need to understand more about the pathophysiology so that the actual science we're doing is better. So really my messages to you are that immune checkpoint inhibitors are transforming oncology. Myocarditis is a rare complication, but actually if we look at the number of patients that are receiving checkpoint inhibitors and we think of the instance of myocarditis versus the instance of atherosclerotic events, we mustn't miss the wood for the trees, and we need to recognize these patients are likely to have accelerated coronary disease, and therefore potentially further down the line that may be much more important problem than actually myocarditis, which is relatively rare. The diagnosis is very challenging. We need biomarkers to be able to understand that better. We don't really know which therapies are best in those patients that don't respond to steroids, and we've still got too many evidence gaps. So anyone that's got any ideas, please help to fill them. So thank you.
So that was a great talk. Thank you. Any questions from the audience? Yes, Vanessa.
Oh, it's a wonderful talk, Charlotte. Thank you. I'm sure you get a lot of referrals. It says that, well, patient is on ICI, do they have myocarditis? Do a CMR on them. Number one, when you do see them, what do they look like? Is it pathognomonic, or, is a variety of very kind of subtle, or maybe some low grade, inflammation here and there, some very subtle late gut, or if there isn't, do you just sort of report, well, everything is normal. I didn't see anything, but I suppose you could never say there isn't. How do you deal with these referrals?
That's a really good question. So I wear both hats. So I do the imaging, but I also see the patient. So I have access to all of the information, and then I'm making the decisions about treatment as well. So in terms of MRI, I really think MRI is not as helpful as we would hope. I've seen patients who have clearly got florid myocarditis, troponins in the thousands, abnormal ECGs, etc., who have completely normal echocardiograms, and also patients who have got mildly elevated troponin and have floridly abnormal CMR tissue characterization. So we do it in everyone if we're suspicious, but it doesn't. I would never report it as this is not. I can say there's no classic CMR features of myocarditis, but that's not saying they haven't got myocarditis. When I'm sitting in clinic, I rely on the patient's symptoms, their ECG, their biomarkers as well, because the symptoms are really quite often, although non-specific, can be quite characteristic. So you will get a patient who comes in who says, I'm so tired that I cannot kind of do anything at all. And these are patients who've been tolerating life completely fine, and they start on the immunotherapy, they're fine, and then suddenly it's like they hit a brick wall. The ECG is also very helpful, non-specific conduction abnormalities, those kind of changes really can be very useful.
The protocol, do you do whole heart coverage for all the tissue characterization methods, just to be able to sweep through, the whole heart in multiple ways, or do you do a single slice or 3 slices, other than the late gut, of course?
Yeah, so we just do 3 long axis and 3 short axis. But I wouldn't expect it to be that localized in terms of phenotype. I don't worry that I'm missing it particularly.
It would be pretty global if something like that were to happen. Yeah, that you wouldn't miss it with 3.
I don't think so, no.
Thank you.
So I was a bit scared by your talk, Charlotte.
Oh, no.
Hopefully
I was just trying to show how little we know rather than anything else.
So, but if you've got a patient who's asymptomatic with a normal ECG, normal troponin, normal echo, can we relax?
Yes.
Okay, good.
Sorry, simple answer.
Yeah. And I guess the other question was, you showed very high mortality rates from it. Who are the people that die, the people with the most kind of florid clinical presentations who've got, severe LV impairment?
And I think that actually the mortality rates are much lower than that now, to be honest, because actually there's more awareness of it. I think in the early days, there were a lot of people that were being admitted with kind of mild chest pain. They had a troponin elevation, their cath was normal, they were discharged, and they had very mild disease, and actually they didn't do too badly. Nowadays, but the patients, therefore, that were being flagged with myocarditis were those who were presenting in cardiogenic shock and significant arrhythmias. So they were the really severe end of the spectrum to even get recognised. I think nowadays, where most people know about this, at least to a certain extent, patients are getting investigated, and so we're picking disease up at an earlier stage. And how relevant that is difficult to know.
Yeah. And do you give these patients statins?
So that's a really nice question. So there's actually some data, which I didn't show today, showing that giving statins not only has a beneficial effect on overall survival in these patients, but also it has a beneficial effect on progression-free survival of the tumour as well. So it may also be having a slight kind of anti-tumour effect, as well as effect on the cardiovascular system. But there is no data at the moment for giving everybody starting a checkpoint inhibitor a statin.
And final question. What was it? That was a good one. Oh yeah. So who do you stop treatment in? How bad do you have to be for you to say you got to stop your treatment?
Yeah. So if a patient comes in and they've got symptoms, they've got a troponin elevation of more than, say, 3 times normal, or they've got any other abnormal imaging features, then we stop treatment. But it's a big decision to make, mainly because their cancer therapy works very well. On the flip side, if you ask the oncologist and you say this patient's got severe toxicity, they often say if they've had such a pronounced immune checkpoint inhibitor effect in terms of adverse events, then it may be that they've had sufficient anti-tumor effect as well. So there's amazing early trials oncologist called Ruth Plummer in Newcastle, and we were discussing re-challenging with her. And she was saying, well, actually, there may not be a need to re-challenge. If your patients develop very severe myocarditis, they may not need the re-challenge because the anti-tumor effect that they've had may have been so significant that they don't need that.
Yeah. So there may be a silver lining.
Maybe a silver lining.
Okay, great. So fantastic talk.